Chairman, and thank you for inviting us to come and be part of this wonderful meeting. I'm going to talk about, not about OCT, not about angiograms. I'm just going to talk about treating macular degeneration. Now, like rest of the world, Australia also has a problem with macular degeneration, where it's estimated that about 1 in 7 people over the age of 50, which is about 1 million people, have some evidence of AMD. And like other places, it's also expected to double in the years to come. Macular degeneration is 4 times as common as dementia and half as common as diabetes. All diseases are on the increase. As our understanding of macular degeneration gets better with the understanding of the role of modifiable factors such as vascular endothelial growth factors, the last few years have shown rapid changes in the landscape in the treatment of macular degeneration, not only in terms of preserving vision but also improving it. So now we have bevacizumab, we have ranibizumab, and now more recently AFLIBERCEPT in our armamentarium. Now these are very commonly touted slides that you're all aware of in terms of how nice the drugs are, especially ranibizumab, where not only does the vision improve, but the improvement is maintained over time, and similar results with AFLIBERCEPT. Now let's look at what's not said and what's not told about treatment with these drugs. The CAT study showed very clearly that if you inject or if the treatment is given monthly, the results are much better than if they are given on a PRN basis. But what also came out with the CAT study is that the risk of geographic atrophy in patients receiving monthly injections of ranibizumab is more than patients who are on PRN. So here's a situation where we might actually be doing some harm while we are planning to do some good. And the increased risk of GA in ranibizumab is more than the bevacizumab arm. Now that's number one. The second thing is that while the results are shown, we also see that with AFLIBERCEPT and ranibizumab, there are about a third of patients who do not respond. There are a third of patients who have residual fluid, and it is these patients that we are treating them on a monthly basis, perhaps not doing them any good, but also increasing the risk of developing geographic atrophy. It is these patients that we need to worry about, the ones that don't respond. Now, why don't they respond? They obviously have got some other VEGF isoform that they're responsive to, or maybe the vessels have matured and they're not VEGF responsive anymore. Maybe there's the issue of tachyphylaxis, which we all know with other drugs does happen. Maybe the diagnosis is wrong, as was shown with the fluorescein angiogram. Maybe it's developed fibrosis. So there are a number of treatments, number of patients whom we've been treating with anti-VEGF agents who have macular degeneration in our eyes, but they're not just, nothing's happening. So it's these agents that we've addressed in this study, which is patients who've got persistent fluid, patients who've been treated with ranibizumab, and when AFLIBERCEPT came in, we said, oh, maybe if we switch them over to another agent, we might get some advantage. So this is a prospective, open-label study, and we basically looked at patients who were on treatment with ranibizumab and then treated them as new patients with AFLIBERCEPT. These are patients who got intraretinal fluid. These are patients who are on regular injections with ranibizumab. So they then got a loading dose of AFLIBERCEPT, just like 3 doses at monthly intervals, and then depending on the response, we then decided to either extend the injection interval or not. So the first thing that came out, and these are 22 patients that we got, and 3 patients had to be withdrawn from the study, and I'll tell you why. But the first thing that we see here is that of the remaining 19 patients, only 4 of them required to continue with monthly injections of AFLIBERCEPT. The others, we were able, over a 2-year period, to extend the interval between injections. Now, this is the interesting one. If you look at the slide, if you look at the bar diagram on the right, the one to your left, yeah, you see that these are the patients who had intraretinal fluid. So these are the ones where the retina was nice and spongy, and with treatment, thank you. Yeah. So it's these patients here. With treatment, this is pre-treatment, 24 weeks pre-treatment, and then you see that the vision has improved with AFLIBERCEPT. Then you look at the PED arm, you find that here's another group of patients where the vision improved. Then you look at the patients who had subretinal fluid, and you find that there was no difference in the subretinal fluid with switching injections from ranibizumab to AFLIBERCEPT. Oh, that's very good. Now, how does it fit in with the changes on the OCT? Does the central macular thickness change? Yes, in the IRF group or the intraretinal group, you find that the vision improved, the CMT went down. That fits in. That's supposed to happen. You look at the PED group, and you find that even though the CMT didn't change very much, as we saw in the last slide, their vision goes up. And then you look at the SRF group, and basically nothing happens here. So it seems that the location of the fluid almost decided what was going to happen. Looking at the 2-year results, the intraretinal fluid arm, it was fine. You know, the gains were maintained, the central macular thickness reduction was maintained with AFLIBERCEPT. Look at the SRF arm, the subretinal fluid arm, and it didn't make any difference, neither to the SRF nor to the fluid, or nor to the vision. And you look at the PED arm, you find here that the visual acuity is maintained, the low one, the visual acuity actually gets better, but the CMT is maintained. So here's a situation where the fluid's not reducing, but despite treatment, patients are actually getting better. Coming on to the side effects, we had one patient who died of a heart attack, one patient who was diagnosed with aggressive bladder cancer, and obviously were not included in part of the study, but we do not consider these to be directly related to AFLIBERCEPT. Now, here are some examples. Here, a gentleman we've been treating for a long time with intravitreal ranibizumab. He's sort of 6, 7.5. He's still got fluid there all the time, and he's on 4 weekly treatment. This is after his loading dose. You see that he's dried up quite well. 6 months, vision maintained. The retina is still dry. And then 1 year and 2 years post-switch, he's doing well. But he's on 5 weekly AFLIBERCEPT injections. Here's a lady, a one-eyed lady, been treating for a year with intravitreal ranibizumab or Lucentis, absolutely no response. Sometimes you'd say, why are you bothering treating her? But she's one-eyed. And without treatment, her vision and swelling gets worse. We switched her over. This is how she is after 1 year when we switched her over to AFLIBERCEPT. This is how she is after 2 years. And her vision has improved to 630, which for her is a big deal. Another lady with a PED, after loading, vision still 618. After 6 months, vision 612. The PED remains the same. Year 2, year 3, no change. Vision 612, 612, and the PED remains the same. There's another lady with SRF. After one injection, 618. After loading, 618. At 8 months, 618. SRF remains 1 year, 618. And after 2 years, she develops geographic atrophy. There's no fluid. She's 624, and that's how she is. So this is the third patient who we withdrew from the study, and I'll tell you why. This is his other eye, where he had a symptomatic PED, which we treated and controlled with intravitreal Avastin. And, he's maintained with Avastin every 9 to 10 weeks. Vision is stable. He's happy. Whenever he feels things get a bit funny, he comes for treatment. This is his other eye, with a large dome-shaped PED, treated with Lucentis. Nothing happened. We included him in the study. 3 months, 3 doses, nothing happened. And he said, Doc, I want to get out of the study. I want you to use Avastin on me. So I said, all right. After all, and that is how he is. After 3 doses of Avastin, the PED is beginning to settle down. Then he developed a cataract. We did a cataract surgery for him. He's 6'6". His PED sort of remains, and he's happy on Avastin. So now you've got a situation where we've been through the whole thing, and he's come back to what works best for him. Anyway, getting back to the study of switching, this is one of two prospective studies that actually addresses the issue of the outcomes after switching patients who were sort of stable but still had fluid on intravitreal Lucentis when we switched them to AFLIBERCEPT. Before we go on to the last bit, the question is, after this, I realized, do we really need to dry all the fluid? Especially, we know that intraretinal fluid is something that correlates very well to vision. You dry it, vision gets better. It comes back, vision gets worse. So we take intraretinal fluid very seriously and work hard on it. Subretinal fluid, on the other hand, one does not need to be as aggressive treating it as we have been in the past. Also, early intraretinal fluid, or what looks like intraretinal fluid, could possibly be VEGF mediated. But when you've got a patch of intraretinal fluid that's just not going away, it might be an area of necrosis. It might be an area of chronic change. And one needs to look at it in that context. So back to the study again regarding the switching. I think AFLIBERCEPT in patients with unresponsive fluid to Lucentis is a useful agent that results in the improvement of vision. But the study is small, so you can't really make too much in terms of claims or statistical significance. The improved vision, as you can see in some situations, is not always associated with changes in anatomical parameters, especially with PEDs. Now, unlike naive patients where the results are quick and in 3 weeks or in 3 injections you get good results, when you're starting to treat patients who've been on other agents, you find that the results are actually much delayed. So the improvement takes place between week 24 and 48. And so the thing is to carry on with treatment and not expect the same response as you would in a patient who's naive. We've gone through the different fluid areas, and then I think the significance of fluid in different parts of the retina seem to be different. And we think that while our experience shows that patients do improve, the main situation here is that there are 3 agents available now, and if patients are not responding to one, I think one needs to assess and see what's going on and try using another anti-VEGF agents. Of course, time will tell and other studies will tell and give us other pathways of handling these 1/3 of patients who just don't seem to respond. Thank you.